Oh, yeah, you would get that anyway. I'm good, how are you? So I have 2 cards.
Oh, 30 minutes.
Okay. Oh, I have a...
Oh, okay. For the entrance?
I'm going to wear it. Well, here we do. So anyway, they're my card. I can give them to you tomorrow.
Okay.
Did you send an email about all that?
What are the days? System.
All right. Everybody grab some food and sit down. We've got a lot of unique information, I think, worrisome information here that Mike's going to relate to us. So, firstly, just the last party of the year is going to be on the Tuesday, the 22nd at Xarelto. Graduation for our second-year fellows and other fun and games. We'll send out a reminder email about that as well, and I'm working on parking over there. So that's another nuisance. I don't know if Mike got interested in this because he started doing some work regarding Xolair and contracts with Xolair. He could sort of explain what the motivation is, but I know he's studied this and really put an immense amount into it. It's not something we talk about, it's something we need to know about. And so I think he's developed so much information he's actually going to split this into 2 presentations, one now, today, at the end of this year's sessions, and then we haven't picked a date, but if you want, very early in the beginning of next year in September. I've got the first speaker of the year arranged, but Mike, if you wanted, you could be the second speaker of the year, so there'll be continuity on this topic. So anyway, he's going to talk about the U.S. healthcare system and, at some point, comparison with systems in other first world countries, and I don't know what beyond that. All right, thanks.
Not beyond.
Okay.
Yeah, I think I got interested just being a consumer and a physician and living in this changing healthcare environment, and then going through this recent political system where a lot of it seems to go around healthcare in the U.S. So in thinking a little bit about my disclosures, I originally put I had no disclosures, but in truth I do. If I'm in U.S. healthcare, I'm a consumer. So my annual premium cost for myself and my family is over $27,000 a year with a $1,500 deductible. And if many of you guys have big companies that you work for, you don't potentially see that number, but someone does. So your company's paying a big number for you and your family to have health care in the United States right now. I'm also a provider. I prescribe medication for my patients, and sometimes that can be extremely challenging in this day and age. Often we need authorization for a medication. Once we achieve authorization, sometimes we're told 6 months later that medication now is not on the formulary because the pharmacy benefits manager decided to change that, and we have to get authorization again for a different medicine. Sometimes I need to use samples, discount cards, and even Canadian pharmacies to get medications for my patients so they can afford it and be on what seems to be the right treatment for them at the time. And I'm also a participant in the healthcare system in that I bill insurers for providing the care that I see patients. So I think if we're all honest, we're all part of this system, and none of us have no disclosures. So again, just in delving into this talk, I quickly realized I couldn't do it in one talk. At some point, I had 250 slides, and it was just I was sort of having anxiety trying to figure out how to get it down to a reasonable talk. So this year, we're going to do part 1, lack of universal health care, how that costs individuals and society. We'll do a little bit of comparison on healthcare parameters, how we compare. And we'll sort of delve into how pharmaceutical costs can impact the U.S. healthcare system. And then hopefully next fall, we'll talk about medical device costs, hospital costs, health insurance influences, and then some specifics on some other first world countries, how they do it differently, whether it's better or worse. Let everyone else decide. If you want to delve into this a little bit more on your own, I highly recommend this book, written by a physician, and it really is pretty illuminating in terms of how our system's gotten a bit dysfunctional, how you can take it back. I read that section. It didn't seem to be a perfect sort of solution, but it really will give you an idea on how the U.S. healthcare system is not quite functional. So we're going to start with a quote from Mo Brooks. He's an Alabama Republican, and he was making the case at the time, once Donald Trump was elected, why we should change from the Affordable Care Act to what could be called Trump Care. And he said it will free healthy people from having to pay the cost of the sick. It will allow insurance companies to require people who have higher health care costs to contribute more to the insurance pool, therefore reducing the cost of those people who lead good lives. They're healthy. They've done the things to keep their bodies healthy. Assuming that one can, be healthy in the good way and keep cancer away, heart attacks away, motor vehicle accidents away, MS away, etc., it's just totally foolish. If that, happened, obviously this would eliminate pre-existing conditions protection that did come in with the ACA. So let's talk about a woman who did lead a good life, and what happened to her. So 50-year-old widow, 2 teenage kids, had been complaining of headaches and vomiting. Her teenage son called an ambulance. The paramedics came, evaluated her, said that she had food poisoning, and sleep it off. She became confused and groggy at 3 a.m. She was rushed to a hospital in Norfolk, Virginia, and a scan showed that she had a subarachnoid bleed. She was taken by helicopter ambulance to a larger hospital 160 miles away for emergency surgery. And fortunately, she slowly recovered. She felt lucky and grateful to be alive. Then she started getting bills. She got $16,000 from the local hospital. She got $40,000 for bill for the air ambulance, $24,000 for the doctors at the hospital that did the surgery. That bill was later changed to $54,000 for the same physician group, which included a $240 late charge, and then finally the hospital charge came, which was over $350,000. So her bill now totaled about $500,000. She was always law-abiding, healthy, good citizen, paid all her bills. But unfortunately, she had fallen on some hard times. She received about $2,000 a month in Social Security survivor benefits since her husband's death, and she had about $100,000 of the death benefit from an insurance payment in a retirement account. She'd raised her 2 children, working in print shop, but never made more than $15,000 a year. And the patient at this time of her illness, her subarachnoid bleed, was uninsured. When her husband had died, she continued to cover her 2 school-aged children with extensions of his health insurance at a cost of $400 a month by paying for COBRA. She took odd jobs. None of them offered health care insurance. In 2010, when the COBRA plan ran out, she tried to get insurance on the commercial market at the time. But she was denied by all companies she applied for because of, quote, pre-existing condition. She had once taken a medication for mild depression. This would no longer be legal with the enactment of the Affordable Care Act, but in 2010, you could deny people for taking an antidepressant as a pre-existing condition. She quit her job so her kids could qualify for Medicaid. So at the time, the patient, as a sign of good faith, paid $1,500 to the hospital, $1,000 to the doctor, and asked for an itemized bill. 1 month later, 60 pages of an itemized bill came. The bill was still incomplete and had a lot of charges that didn't make sense to her and an attorney that was looking at the bill at the because the patient was so mentally impaired for a period of time in the perioperative period, the hospital had granted her father power of attorney for life and death decisions. Nonetheless, the forms that she had signed on admission to the emergency room were deemed proof of her consent to pay by the hospital. She did a little research and found out what Medicare would have paid, and that would have been between $65,000 and $80,000, and what a military insurer, TRICARE, would have paid, and that would have been about $72,000. And she was offered to pay that amount to the hospital, and they said no, that's not enough. They wanted full payment. She offered $100,000, all of her retirement account, but the hospital declined that. She drove to the hospital to talk to the people in financial services, and she was told, we can put a lien on your house if you don't pay the bill. So the hospital we're talking about is the University of Virginia Health System in Charlottesville. It's a hospital of one of the most eminent public universities, founded by Thomas Jefferson to educate leaders in public service. But obviously a lot has changed since 1819. Like many medical centers, the University of Virginia has turned at least some of its billing and data collection over to, quote, professionals. Third-party contractors have no pretense of charitable mission. They're often paid a percentage of what the patient owes and pays. So they want everything they can get. Studies have shown over and over that hospitals charge patients who are uninsured 2.5 times more than those who are covered by health insurance, because they have a negotiated rate through the health care insurance. And they're charged 3 times more than the amount that's typically allowed by Medicare. So universal coverage in many countries such as UK, Switzerland, Japan, Germany, make the number of bankruptcies related to medical expenses pretty much zero. But 2014 survey of bankruptcies filed in the U.S. between 2005 and 2013 found that medical bills are the single largest cause of consumer bankruptcy. Between 18 and 25% of cases directly prompted by medical debt. Just go on from here. This was in last month's New England Journal of Medicine. And it basically, if we look at 0 time, that's when a person is hospitalized. The chance of going or declaring consumer bankruptcy goes up significantly in the 5 years after someone is hospitalized. So just this hospitalization alone in the United States increases the likelihood of consumer having to declare bankruptcy in the U.S. This is data from March of 2018. So another quote, we have the finest healthcare system in the world. That is what the Affordable Healthcare Law will destroy. Republican Ron Johnson stated that when Obama was trying to pass his Affordable Care Act. And then another quote from John Kennedy, no matter how big the lie, repeat it often enough, and the masses will guard it as the truth. And we see that, I think, unfortunately, over and over today with our orange president with poofy hair. So, since 2004, reports from the Commonwealth Fund have consistently ranked the performance of the U.S. healthcare system last among high-income countries, despite the fact that we spend far more on healthcare than all other countries. It's true, we offer some of the most specialized and some of the most technologically advanced treatments in the world, but we also fail to achieve a level of performance that other first world countries' healthcare systems do. Data from the Organization for Economic Cooperation and Development showed that of the GDP, over 17% of the money spent in the United States went to healthcare. That's dramatically higher than all of these other first world countries, which generally hover between about 9 and 11% of their money, GDP, spent on healthcare. So a tremendous more amount of money, as you can see here, spent on healthcare If you look at it per individual, per capita, again, you see the same pattern with the U.S. per person spending over $9,000 per year for health care, where the average for the OECD countries was about a third of that, with many of the countries being somewhere between half and a third. A recent international study compared 11 nations on healthcare quality, on healthcare access, efficiency, and equity, as well as indicators of healthy lives such as infant mortality, and unfortunately, again, the U.S. is pretty low on this list, in fact, last on the list. So in 2015, we spent almost 2 to 3 times more on health care as the average of other countries with comparable incomes, and despite spending more, the results don't always equate in terms of better health. Looking at Italy and Britain, for example, which spend $5,000 less per person per year than the United States on health care, yet the population of each of these countries has a higher, longer life expectancy. And here you can see the U.S. life expectancy from 2005 to 14. 2014, it was about 78.8, I think, years life expectancy, with Germany and UK exceeding it over closer to 81 years life expectancy for spending half the amount of money. So broadly speaking, what's universal health care? The WHO defines universal health care as a system where everyone has access to quality health and is protected against financial risk incurred while accessing that care. And about 35 of the OECD member countries, 32 of them have introduced plans that now match the WHO criteria for universal health care. Despite the U.S. legislation, the Affordable Care Act in 2010 that moved the country closer to achieving universal health care, costs have continued to rise, and still 26 million Americans are uninsured, and probably going up with the changes with this recent House of Republicans and Senate have passed. If we look at, again, universal health care, most of the first world countries have 100% or close to 100%, and it's really unique that the U.S. doesn't. And you might say, well, it's only 10%, but 10% has a huge impact on people's lives in terms of bankruptcies, in terms of worry, and in terms of cost to the system. Healthcare prices in general are higher in the U.S. compared with just about any country. If we look here, put a little blue star for the United States on various things that get done in healthcare. So bypass surgery is much more in the U.S. compared to these other countries. If you look at appendectomy costs, they're much higher in the U.S. If you look at MR costs, they're dramatically higher. Look at Switzerland, $138 for an MR scan cost. CT scan costs are higher. And if you look at pharmaceutical costs, if you say the U.S. is at 100%, then you can see the percentages that other countries pay comparatively to the U.S. in terms of pharmaceutical costs. If you look at a knee replacement in the U.S., the average price is $28,000 compared to Switzerland, UK, New Zealand, Australia, South Africa, Spain. If you want to go up to the 95th percentile or down to the 25th percentile, I'm not sure why they gave that for the U.S. versus none of the others, but in any case, it's higher here. They have a statistic called preventable years of life lost, and that's where researchers look at mortality that results from medical conditions for which there is a recognizable healthcare intervention that would be expected to prevent the death of the individual. And while healthcare systems may not be expected to prevent death in all of these instances, the differences in mortality for these conditions provides information about how effectively healthcare is being delivered. And unfortunately, the U.S. has the highest mortality rate for deaths amenable to healthcare among comparable nations that could be prevented. And here's the statistics. Out of 100,000 preventable deaths, the U.S. unfortunately has 112 that died versus all of these other countries, which are Again, closer to 80, 60, 70 deaths out of 100,000. So why do we spend so much, and why do we get maybe so little? First, we have a tremendous amount of excessive bureaucracies. Money is diverted from patient care towards wasteful practices, bureaucracies, and excessive profits. No one's saying people shouldn't be profitable, but there are excessive profits to certain businesses such as hospitals, biopharma, medical devices, and insurance companies. If you look at commercial insurers in the United States, they spend 80 cents out of every dollar that they collect on premiums, and 20% goes to administration, marketing, and profit. In comparison, Medicare spends 98 cents on any dollar to healthcare, and only 2% goes to administration. There's no marketing, and there's no profit. Americans pay more for medications, they pay more for devices, they pay more for procedures, they pay more for hospital care, and they also pay commercial insurance costs, which is marketing and profit, that goes to zero healthcare benefits. Generally, counterfeit drugs cost 2 to 3 times more in the U.S. compared to Canada and Europe, and we'll look at that a little bit more. If you look at medication treatment for hepatitis C in the United States, $84,000 to $168,000 for 3 to 6 months. $900 in Europe for the same medication. For the cost of the company, it's about $136 per cost, which translates into about 100,000% profit in the United States for treating hepatitis C. Before Nexium was available as a generic, it cost about $215 a month in the United States compared to $20 to $60 in Europe. Hip replacement, $80,000 in the U.S., less than $14,000 in Europe. Again, MRs, we looked at the difference in costs in the slide earlier. Prescription medications per capita is far higher in the United States than in 9 other high-income countries. That was not always the case. We were pretty close in the 1980s. And then somewhere in the 1990s, 2000s, 2010, spending on prescription medications grew at an exponential rate, and I don't think anyone has an explanation for that except profits, basically. And so if you look here in 1980, the U.S., which is in this sort of orange, was about the same in terms of per capita pharmaceutical spending. And then in 1990s, things started to go a little bit different in terms of the rise. And if you look here, between 2012 and 2014, this slope is pretty impressive. So let's look at a medicine like insulin, right? Over the last decade, the list price of all brands of insulin has increased by 290%. Lilly increased Humalog and Humulin by 7.8% in 1 year between 2016 and 17. And lo and behold, Novo Nordisk down the block here increased Novolog insulin by 7.9% from 2016 to 2017. So these drug makers are facing a class action lawsuit alleging conspiracy that they conspired to raise their prices in lockstep. You don't think 7.8 and 7.9 is lockstep? So, yeah, this is a medicine that was discovered and production was started in 1923, right? So prices are going crazy. Here's rising prices of 10 mLs vial of insulin over time. This is in 96. And this is one company and another company. I wonder why they think they're going in lockstep. If someone can tell me why insulin that was invented in 1923 should have this price increase in the United States, I'm all ears. I don't get it.
So, Mike, is there no restriction, no
Correct.
policing? It's
Correct.
Purely capitalism?
Correct.
Price will go whatever you want.
Shareholders, stock prices, CEOs get their, bonuses. Yeah.
So in other countries, these companies
We'll get
sell.
to it, but
that.
we'll
Good.
get to that. Yeah, yeah. Again, just more examples. Very common medications, including one that we use a lot, Advair. The price in the United States, which is right over here, is much, much higher than all of the other countries. The orange is what the price is listed at. If you get discount cards or rebates and stuff, it can bring it down. Of course, Medicare doesn't allow rebate cards or discounts, so you got to pay full freight if you're the government, basically. Another example, one of the new blood thinners costs for month's worth $292 for Xarelto in the United States, and again, half to a third in other countries. So if you look at people who cited a risk of skipping medications, if you look all the way here, that's like a third of people in the United States who don't have insurance will not take medications as prescribed because of cost. If you look at folks in the United States who do have insurance, still there's going to be a higher skipping of medications because the cost, even with insurance, is much higher than most of these other countries. So here's a patient who breaks the law every month to stay alive. She has type 1 diabetes and she needs insulin. So the cost, as we saw, of insulin has gone up. She estimated that it would cost her $3,000 a month to stay alive using insulin without insurance. So she buys her insulin from Canada, where a comparable bottle costs $21 for 10 mLs. And again, if we look back, Frederick Banting and his colleagues Collop and Bass were awarded U.S. patents on insulin and the method of making it in 1923, along with the Nobel Prize, I should say. They sold these patent rights to the University of Toronto, they were Canadian, for $1 each. So the University of Toronto bought the patents for insulin production for $3, and then the university gave it to the pharmaceutical companies the right to manufacture it royalty-free. So there's a difference in terms of how things were done then and certainly how things are done now. And again, 19 million Americans, or 8% of the population, import medications from other countries to save money so they can eat. So why do we pay more? Well, there's a ban on federal negotiation. The U.S. law prohibits Medicare from negotiating prices directly with drug companies. I don't know why, but I assume there has to be something about lobbying going on here, but they're prohibited from negotiating prices. So in the U.S., drug makers set their own prices, and they have the ability to increase prices as much and as often as they wish. Brand name prescription medications in the U.S. on average have increased 100% in the past 6 years. So from 2012 to now, 100% increase in the same medication. And it just keeps going on, basically. And the difference in Europe is government often sets the drug prices. They negotiate the price initially, and as the price ages, they negotiate steeper discounts because the medication is not new anymore. So in Europe, it starts lower and goes lower. In the U.S., it starts higher and goes higher. So again, you can charge whatever you want. I'll give you a few examples. And I'm using companies that we know, so you'll be, but this is not just companies or medicines that we know. It's every company, as I showed you in insulin. So Xolair, every April 1st and every October 1st raises their price 4%. So 8% a year, every year they're out. The price of the medication goes up. Humira has risen from $19,000 a year in 2012 to more than $38,000 today, and that's after rebates. So that's an increase of 100% in 6 years. EpiPen, I don't think I have to say anything else. If you look at competing products, they generally end up charging about the same high price rather than competing in price. So if you would think in a capitalistic system, okay, this is purely capitalistic. We've got a Ford, a Chrysler, a Dodge. If you price one a little cheaper, you'll get market share. But instead, they tend to charge almost to a penny the same amount. And You can look at the 3 new anti-IL-5 products. They're great medicines. We like to use them in patients. We get our patients benefiting from them, but they all cost about exactly the same for a year's worth of medicine, having come out within the past, year and a half. And they're all delivered differently, right? They're delivered with different frequency. They're delivered sub-Q. They're delivered IV. But if you add up the cost for the year, they're the same. Or you can just buy a medicine and then raise the price. We all know this particular gentleman, Martin, I can't even pronounce his last name. So he bought the rights to a cheap generic drug to treat parasites that have been on the market forever and raised the price from $13 a pill to $750 a pill. Now, he was taken to court, but it wasn't for this. It was for hedge fund sort of shenanigans. So many of the newer medicines have such high costs because they're biologics and they do take a lot to produce and make. And so medicines for chronic diseases like MS, asthma, atopic dermatitis, cancer, cardiac diseases, arthritis, many others are really expensive, these biologics. If your insurance company approves it, they'll pay 80% of the cost of that biologic or that medication. But 20% of a very large number is still more than most patients can afford to pay on an ongoing basis. So typically, biopharma companies have developed ancillary companies that will pay the remaining 20% of the cost of the medication for the patient, which is great for our patients. It really enhances the patient's ability to stay on these medications, but it also raises the cost of the medications in the U.S. compared to all other countries. So the companies are receiving more money, getting 80% of the price of the medication in the U.S. than they would be receiving 100% of the negotiated price in all other countries. So they're very happy. The 20% patient assistance program that they set up is also tax deductible for the company, so they get a tax benefit there. And so the patient assistance programs lowers the out-of-pocket cost for patients, but the programs stick insurers with the bulk of the bill, which in turn is passed on to consumers through high premiums and high deductibles. As my grandfather told me growing up, there's no free lunch, and the free lunch is not there. So the insurances pass on the cost to the premiums and deductibles. So the medications ends up costing the U.S. healthcare system more than other countries where the price of the medication is, again, initially negotiated and then comes down each year rather than goes up. So Hatch-Waxman in 1984 was a law that was trying to clarify pharmaceutical makers the length and extent of their patents, how they were protected, and it offered supposedly generic medications financial incentives so that they would be motivated to bring in cheaper versions into the market. It didn't quite work out that way, but that was the goal. So Hatch-Waxman Act allowed for 3-year extensions if new clinical trials reported a change in a dose form or delivery form. It gave manufacturers 7 years exclusivity for orphan drugs. It gave them 6 months extensions for doing some pediatric trials. And it also allowed them a, quote, 5-year extension for time lost in regulatory review, whatever the heck that is.
That's guaranteed.
So let's look a little bit how pharmaceutical companies have used the patent laws to extend their medications and keep raising the prices. So if we change the delivery to a, quote, new product, generics must be exactly identical dose form and delivery of the brand name for a pharmacist to be able to substitute. So each change in delivery succeeds in delaying competition from generics for years. So if we use an example, an old treatment for ulcerative colitis for many years was mesalamine, an affordable, decades-old drug under the name Asacol. But over time, in the U.S. at least, this medication rose, and in 2011, it cost $750 per month for Asacol, which had been around for a long time. It was supposed to go off patent in 2013, but generic medication never materialized. Right before that was supposed to happen, the company introduced a new improved product They came out with a longer-acting version, a gel-coated version of the older medication, and they stopped producing the older version. So there couldn't be a generic since this was a new gel-coated version. Many of the patients complained that the new thick gel coating was hard to swallow and was so well protected that it sometimes came out entirely whole in the bowel movement. And the patient sort of didn't like taking the gel coating, so he said, let me peel the gel coating off, and what he found underneath was exactly the same old tablet that was now in a gel coating. So some of these patients ended up buying their old medication from Canadian pharmacies for $55 a month instead of $800 a month for the branded medication in the U.S. In England, if you have special private insurance, you can still get it for $55 a month. If you don't have special private insurance but standard National Health Service, you'd get that medication for $12 a month. So the price of this medication, long off patent, increased 500% in the United States, even as the price decreased for patients in other developed countries. This is unfortunately a pattern that we see over and over again. I think we're all aware that in the 2000s, based on the Montreal Protocol, CFC propellants were stopped. And so manufacturers came out with albuterol inhalers with HFA propellants. And the price of the common asthma inhaler, albuterol generic, rose from $10 inhaler to over $100 an inhaler because it now was a proprietary HFA device. And this, in quotes, is my thoughts. I don't know if anyone else knows, but this was the first time I had ever seen, and I don't know if I've ever seen it since, where a generic medication became a trade medication. Has anyone seen that before? So you have a generic medicine costing nothing, and now it's a trade name that costs a lot of money. In Australia, albuterol is still generic, and it costs about $7 to $9. Other patent plays that happen, you can change the concentration of the medicine, you can use enantiomers, you can use combinations, and you can sort of get around patents. So again, we can think of changing concentration of the same medicine. You can think of Patanol, Pataday, Pazeo. It's the same medication with more concentration. You can think of Astelin and Astapro. These things don't happen randomly. They happen exactly when the patent's supposed to be up. You can think of enantiomers. It's basically half of the same molecule. The change usually doesn't have a dramatic clinical significance, but again, it extends your patent. You can think loratadine and desloratadine. You can think cetirizine and levocetirizine. Or you can come up with a combination product. This one's pretty classy. Horizon Pharma in 2011 got approval for its first product, Duexis, painkiller, which was a combination of two over-the-counter medications, ibuprofen and famotidine. If you buy these medicines at Costco separately, you get them both for $9 a month. But Duexis is covered by 5 patents, and it costs $1,600 a month. Horizon Pharma developed a team of 160 sales representatives doing what to the healthcare system in the United States, adding what benefit to the healthcare system in the United States. And by the end of the year, gross sales for Duexis was $88.5 million for 2 over-the-counter medications. There's a strong motivation with Hatch-Waxman to file patent extensions because even if a generic manufacturer challenges these extensions under the Hatch-Waxman law, just filing for a patent extension sets off a mandatory 30-month halt on FDA's consideration for generic entrants. So, and I remember a number of medications that were supposed to go off and a generic was supposed to be on, and they filed an extension. There's a lawsuit, you get a delay, and eventually the generic comes out, but 30 months is a long time in trading medications.
And how often do the pharmaceutical companies pay those other people not to have a patent?
Yeah,
you know what I mean?
That's at the bottom.
Okay. Pay the other.
That's even a better point.
Yeah, exactly.
Well, this one's actually best. This one's best because you get an automatic 30-month delay. And it's been estimated that for every 6 months of delay of generics entering the market can be worth billions in profits and billions in added healthcare costs. Okay. So brand manufacturers will sometimes actually pay a generic manufacturer to agree to delay their generic application, a tactic which in the industry has become known as pay for delay. So I'll pay $1 million, and it'll give me a couple of $1 billion if you don't, put out that generic. Again, helping healthcare costs how?
There was an article in the New York Times the other day that companies are also denying generic manufacturers examples of their product so they can create bioequivalent, and so another scheme, just holding back so they can't duplicate.
It's too expensive for them to buy the medicine to duplicate it. So again, this is very different than, I think, how things were not that long ago. Early inventors of medicines or vaccines often made at most only half-hearted attempts to gain patent protection for their discoveries. Edward R. Murrow asked Jonas Salk, who owned the patent for the new polio vaccine, who owned it? And he said, well, the people, I would say. There is no patent. Could you patent the sun? I can't imagine someone saying that this day and age. In fact, at that time, legal thinking felt that the vaccine was unpatentable. The research had been done by many people. There was both public funding involved and millions of contributions to the March of Dimes was used in the development of the polio vaccine. Not so now. Patents are awarded for treatments derived in part from research done with government, NIH funding all the time. There's rampant direct consumer advertising by pharmaceutical companies. If you watch TV, every third commercial seems to be a medication that is being marketed. If you open up a magazine, read any magazine, there's tons of advertising to consumers. In fact, drug companies spend a lot more on marketing than on research and development, according to the National Academies of Sciences, Engineering, and Medicine. And advertising to consumers rose from $166 million in 1993 to $4.2 billion in 2005. And by 2006, it makes up nearly 40% of total pharmaceutical promotional spending. And this direct-to-consumer advertising adds, as far as I can see, nothing to healthcare. Why do you think it's done? Well, it increases market share, it increases profits, but it doesn't do anything to increase delivery of healthcare. In 2000, Merck spent more advertising for Vioxx, $160 million, than Budweiser, Pepsi, or Nike spent. That year, the drug sales, and you can see why, for Vioxx, topped $1.5 billion, and 25 million people took the drug. Of course, even before it was approved, a reviewer had raised some concerns about data suggesting might increase risk of heart attack. And finally, obviously, we all know that the drug was withdrawn. 88,000 heart attacks were attributed to it, nearly half of them fatal. And the company actually paid a criminal fine of $950 million for its marketing and sales tactics. Last sort of direct-to-consumer drug advertising. Again, if you watch TV, you have seen this ad. Non-24 affects blind people who have difficulty with a normal sleep pattern. So this company, Vanda, developed a new molecule for non-24 called tazimeltium. It basically resembles melatonin and attaches to the melatonin receptor, producing similar effects. In 2014, the FDA granted approval as an orphan drug for non-24. It was really no better than melatonin itself, and the medication was priced at $96,000 a year, or $267 a pill. So now you have a prescription for a medicine that's over $200 a day, that's basically as effective as melatonin when used properly, which you can get for $6 for a bottle of 100 of it. Now, that was not the market Vanda was going after, because it's a pretty small market. But they had tried doing trials for general insomnia, But the drug had such lackluster results, it couldn't compete with other medications that were already approved for insomnia. Ambien, Lunesta, Sonata, it failed miserably. So they looked for an expedited approval to treat this orphan disease. And instead of having to test them rigorously in general populations, they can do just a dozen, patients. They can do it in 6 months rather than many years. And they can focus on highly surrogate endpoints. But once the medication is out, they can advertise the heck out of it. And many people without non-24 are now prescribed the medication for basically $96,000 a year melatonin. So I think we're going to end here. We're coming to the sort of end. We'll take some questions. Next year we're going to talk a little, if you think pharmaceutical costs are crazy, we're going to get into real craziness with medical device costs, hospital costs, the rise of health insurance industry, and then hopefully how some other countries do it. And there's a lot of different ways that other countries do it. There's not one way. For every country, there's a slightly different way to deliver universal health care. So thanks for your attention. Any questions at all? With that uplifting talk.
Are there any solutions other than changing who's in charge of the government?
Yeah.
I don't know the answer to that. I think changing who you vote for is important. I think no so more than now. But even, so when we get into medical devices, it's medical device makers got hit with the Health Care Affordable Act where they had to pay a 2.3% tax. And Minnesota and Massachusetts are states that have a lot of medical device makers in it. And so you have very liberal Democrats like Al Franken and Michelle Warren and Kovachev, I can't pronounce her name, very liberal Democrats siding with Republicans so sort of to put a delay on that excise tax for medical devices. So they lobbied, they spent a lot of money, but they didn't spend nearly as much money as they gained when they got their extension to not pay that excise tax. So, yes. Yeah, get rid of lobbyists and you'll have a better healthcare system.
It also seems to me that in spite of the fact that we passed the ACA, costs the last couple of years have just even gone up more exponentially.
I don't know how you can raise price on just about every medicine 100% in 6 years. Medicines that are 20 years old, 30 years old. In case of insulin, 80 years old?
And there's no laws in place.
No, correct.
Well, it strikes me that half of it's a catch-22. If everywhere else is doing the low model, and these are for-profit companies, we're paying for it.
We are.
Right?
We're paying for the whole world.
And the truth of the matter is some of the best research and the best development is being done here. So we should not say that. It is. It's unbelievable the great stuff that's being done. But to have a medicine and just keep raising the price, versus having you get to charge this amount for 6 years and then we want a little reduction, which would seem reasonable. That's not done in the United States. You should make a profit. Should you make excessive profits?
An example that we all relate to, we're using Xolair every day. I must have had administered 6 doses yesterday. So how in the world do we accept the company and people we deal with who, for no reason, on an old drug, are raising the price 8% a year?
The medicine helps your patient, I assume. You're trying to take care of that individual at that moment, and you deem that the best treatment at that moment for that patient. So I understand why you, I, or any of us here do that, but that's not what we're talking about in this talk.
Yeah, but it seems to me that we're, to some extent, responsible here. Now that we know this, You would think we
Well,
have
there's no
some
competitor.
influence on telling the
But even-
company this
but
is
even-
unconscionable.
Well, I mean, you can say that.
Yeah.
I've said it. I mean, and the person that you're going to say it to is not the person who's setting the price, and they'll say, yes, I understand your concern.
That's the end of the conversation.
Yeah, you have to stop lobbyists and you have to vote different people in. Yeah.
Well, you young people who are turning out to run this country and the healthcare system, you bear a responsibility here to know more than just how to take care of patients. This system is, seems to me, is gonna.
Well, it seems like people are trying to get every cent out of a system that they see is heading off a cliff, and they want to get every cent out of it before the cliff arrives.
Is this like population control? To make drugs so expensive?